Center is Dr. Giampaolo Bianchini, and we'll be done in person. Title of the talk is Circulating Tumor DNA Dynamics in Patients with Hormone Receptor Positive, HER2-negative advanced breast cancer treated in first line with ribociclib and letrozole in the BioItaLEE trial. Thank you.
Thank you very much. On behalf of all my co-authors, I would like to thank the scientific committee for selecting our work for presentation. This is my disclosure. Ribociclib significantly improved PFS and OS regardless endocrine therapy partner, line of therapy, menopausal status across the 3 Mona Lisa studies in patients with ER-positive, HER2-negative advanced breast cancer. However, data on predictive biomarker of response to ribociclib are limited and inconclusive. ctDNA analysis is emerging as an attractive, not invasive approach to characterize tumor biology, describe its evolution over time, and predict prognosis and treatment benefit. Here, we assessed the impact of baseline and dynamic ctDNA analysis in postmenopausal patients with estrogen receptor positive, HER2-negative advanced breast cancer treated with first line with ribociclib plus letrozole in the BioItaLEE trial. In this trial, 287 patients were enrolled. As indicated, eligibility criteria were similar to Mona Lisa 2 study. The primary objective of this study is to identify circulating tumor DNA alteration, characterize how they evolve during treatment, and evaluate their possible association with clinical outcome. For this purpose, we prospectively collect blood, serum, and plasma at baseline, at 15 days during the first cycle, on day 1 of cycle 2, and at first imaging. Samples at progression has been also collected, but they are not an object of this presentation. ctDNA analyses were carried out using a 533 amplicon custom panel with an amplicon covering that covered 39 breast cancer-related genes. Target mutations were defined and single nucleotide variant, insertion or deletion detected at baseline. When multiple target mutations were detected in the same patient, the one with the highest variance allele frequency was considered. Variance allele frequency clearance was defined as disappearance of the target mutation. The association between ctDNA and PFS was assessed by using multivariate Cox models adjusted by time of metastatic occurrence, luminal tumor type, assessed by immunohistochemistry, visceral metastasis, and number of involved organs. Here is presented the table reporting the 39 breast cancer-related genes investigated. 287 patients were enrolled as intent to treat population, 7 patients were excluded to protocol deviation, and 17 failed to provide a valid pretreatment sample for analysis. At the end, 263 patients represent the biomarker population suitable for translational study. In this patient, median follow-up was 26.9 months with 23.4 months of median PFS. The rate of successful collection of sample at the 3 following time points was very high, as indicated. Patient characteristic of the biomarker population is not different from ITT. Median age was 66, 28 was luminal B, 39 with de novo metastatic disease. Visceral disease was present in 43%, and 19 have 3 or more involved organs. At baseline, target mutations were detected in 100. At baseline, target mutations were detected in 113 patients, representing 43% of the biomarker population. The group without target population detectable at baseline was associated with a 59% decrease of the risk of progression with a p less than 0.0001. A strong and robust ctDNA dynamic was observed during the first cycle, as illustrated in the graph, describing the variance allele frequency dynamic at day 15 and at day 1 of cycle 2. Early variance allele frequency clearance, which means disappearance of the target mutation, was observed in 47.1% at day 15 and 52.4% at day 1 of cycle 2. Then we evaluate the association of early ctDNA dynamic with the clinical outcome. Considering only patients with baseline target mutation, the group achieving a variance allele frequency clearance at day 15, which corresponds to almost half of the patient, was associated with a statistically significant lower risk of progression with a hazard ratio of 0.51 and a p-value 0.022. We perform a similar analysis on day 1 of cycle 2, and what we found is that at this time point, 52.4% of the patient has a disappearance of the target mutation. Also here, the achievement of the clearance is associated with a 56% reduction of risk of progression with a p-value of 0.005. Here we present an analysis which includes 150 patients without detectable mutation at baseline, representing 55% of the biomarker overall population. We have previously shown that this group has overall a lower risk of progression. Within this group, 34 patients, corresponding to 22.7%, have an appearance of mutation at any of the later time points. As expected, the group that maintain not detectable mutation at the time point that count has a significant lower risk of progression with a hazard ratio of 0.45 and a p-value of 0.01. Then we evaluate how much was informative the assessment of ctDNA at day 15. And what we found is actually that we observed to under 38 patients with available sample at this time point. And as you can see, there are 2/3 of this population, corresponding to 159 patients, who had no target mutation detectable at day 15. And this group has an extremely favorable outcome with a hazard ratio of 0.32 with a p less than 0.0001. Notably, within the group with detectable target mutation, we observe that patients with a variance allele frequency below the median, shown in orange, as a trend of better prognosis compared to patients with a variance allele frequency above the median, described in green. Finally, we evaluate whether baseline and day 15 ctDNA provide independent predictive information. As indicated in the table, in multivariate analysis, ctDNA analysis at both time points retains statistical significance. In particular, no detectable mutation at baseline is associated with a lower risk of recurrence, with a hazard ratio of 0.57 and a p 0.019. No detectable mutation at day 15 is also associated with a lower risk of recurrence compared to presence of mutation, with a hazard ratio of 0.53 and a p-value of 0.009. In the Kaplan-Meier is indicated the progression-free survival by the 4 groups, achieving by combining the two status at the 2 time point, day 15 and baseline. As expected, the group without detectable mutation at both time points has the lowest risk of progression, and on the opposite, the group with both detectable mutation at either time point has the poorest outcome. In conclusion, the presence of detectable target mutation at baseline appeared to be a negative prognostic factor as has been shown previously by other research. Among patients with detectable mutation at baseline, treatment with ribociclib and letrozole lead to a variance allele frequency clear in about half of the patients as early as 2 weeks. And this pharmacodynamic modulation of ctDNA was associated with a lower risk of progression, suggesting a predictive value. As expected, in patients without baseline detectable mutation, appearance of mutation at a later time point, but early, within the first 3 months, was associated with higher risk of clinical progression. And overall, both pretreatment and early dynamic ctDNA may represent promising and predictive biomarker in patients with ER-positive, HER2-negative advanced breast cancer treated with ribociclib and letrozole. Further studies are warranted to demonstrate the clinical utility of this biomarker, and I would like to thank patients, their families, all Italian co-investigators, the great support of Novartis, in particular Daniela Castelletti, and last but not least, the amazing contribution done by the other 3 steering committee members, Michelino De Laurentiis, Grazia Alpino, and Luca Malorni. Thank you very much for your attention.
Thank you for an excellent talk. The talk is open for questions. As people are coming to the microphone, here you're beginning in that last conclusion to address whether this might be more than just prognostic, that it might be predictive. So can you comment on whether ctDNA detected at an early time point could really be predictive for therapy in this group?
I think that to make this observation in a broader perspective, also for other targeted therapy, an immune checkpoint has been described that the early disappearance of ctDNA is just the early indicator of the activity of the drug. And so if we look at the finding in a general perspective, is quite expected that this information is able to describe an effect of the drug. And this is also very well demonstrated by the fact that the baseline presence of mutation is related with a poor outcome. But the disappearance in this group, that of course can happen only due to the administration of the drug, is associated with a much better outcome.
Okay, thank you. The question at the microphone?
Hi, yeah, very nice talk, great result. I have a question about, more a technical question about your assay. So first, you analyzed a panel of 533 genes, right, for circulating free DNA. I was wondering, for those patients that did not show any mutation at baseline, did you reflex them to a larger panel?
Oh, this was 533 amplicon that uncovered 39 genes in the exon area. Yeah, so unfortunately, there was not so much gene. And we actually have also used, we present at ESMO another panel that covered another, I would say, limited number of genes. This presentation just relied with this test because that was the primary assay that was planning to be used for this primary analysis. We are planning also to look at these additional tests if this information can be somewhat useful.
Yeah, thanks. Second question is, for those patients that did show mutation at later time points on the genes that you assessed, did you evaluate whether increasing sensitivity of your assay could pick those mutations at baseline?
Now, of course, because the assay that you use is exactly the same, the limitation by sensitivity of the assay is exactly the same in all the conditions. This also means that it's also possible that some negative results at baseline that come to be positive are a result of a lack of sensitivity of the test of the baseline sample. What we actually present here is just a description of the fact that when you have an appearance of a mutation at any time point compared to not having this event is associated with a higher degree of progression, probably just because it is an anticipation of what is happening. But different from, for instance, from the other study, this is an early assessment within the first 3 cycles. It is not following the patient, just waiting to the appearance of a mutation.
Thank you.
Okay, thank you. I think we need to